So look, this is a basic guide to surviving HR. It's been about 5 years since I did the shift. 4 years? 5 years since I did the shift. But I know from being there after as a HEMAT that things haven't really changed. It's still probably one of the busiest shifts. It used to be combined with cardiology, but thank God they kind of dropped that during the evening. I think at night time there's still, overnight it's still cardiology. But it used to be the same in the evening. So luckily they've dropped that. This talk's going to be more based around haematology, but I know that you guys have to cover medical oncology, palliative care, B5C, which is a bit of a kind of mishmash. It should really be respiratory, but it has other things in it as well, and C4C is always hilarious to go down to as well. With the inpatient psychiatric unit, we can't really tell who's the patient and who's the doctor. So forgive me if it's a bit skewed and biased towards haematology. A lot of the stuff that we talk about in haematology is applicable to the med-onc ward as well, particularly the oncological emergencies, and we'll go through a couple of those as part of a general overview of haematology. So this is how I imagine you. You can see there's an old guy down here. That's me. I think I just got this picture and realised, obviously, Andrew, that's yes. Anyway, so this guy. No, so this is surviving the shift. It feels a bit like this, I think. The ward, C5A particularly, can get very busy. There is obviously a lot of protocols in place which are followed by nursing staff and doctors as well, and they're there for good reason. But sometimes it can feel like there's not much room for imagination and creativity, bringing your own kind of medical knowledge to the ward. And that's a shame, because you should definitely bring your own experience in other rotations, because that's what medicine's about. There's really great things you can learn in other places which you bring to this ward. Haematology wards around the world are the same. They're nursed by nursing staff who are very well trained and supported, but are very linked into the local protocols. And there are certain things that need to be done, and they're done for a good reason, for patient safety, but it can feel a bit like you are just banging your head against a brick wall. But there's reasons for that. But you have all this other training and experience, use it. And don't be afraid to use it, don't be afraid to kind of consult with the registrar and put your point forward. Because this is residency now, you guys have got through the hell of internship. You're supposed to be able to be thinking a bit more, taking responsibility, and always thinking about patient safety. So the essentials are, so C5A is the main haematology and bone marrow transplant ward at Westmead. C5C has a large inpatient medical oncology and some radiation oncology patients, so that's not that, there's not that many of those patients around. And C5P and C5C have obviously a palliative care patient, where the patients are by definition suffering usually the effects of the disease, which is mostly malignant disease in hematology, though not always. And the treatments that we give can be very, very toxic, including chemotherapy, radiotherapy. So they're suffering from both of these processes. Obviously cancer is seen as a disease of older people, so the medical oncology ward will tend to have older adults with the normal comorbidities of older adults. So you always have to consider them. But there's the kind of more dramatic and emotional aspects of having younger adults with, usually aggressive disease, and usually having aggressive chemotherapy, and that brings with it its own problems. Palliative care, you've got to be thinking of the dying patients, those who are maybe still getting palliative radiotherapy, but ultimately not having a curative treatment. Are they the pre-terminal phase? Are the terminal phase? Are the patients happy with that? Are the patients in a place where they've accepted what's happening to them from their treatment point of view? Do the teams that the day teams are they communicating with the patient, and there's a good relationship, and the patients are aware of what's happening with their care? Sometimes patients have a kind of misconception that they're getting a treatment because it's curative, and you get called to see them in the evening, and that colours your assessment of them. So there's emotional and psychological aspects of caring for these patients. There's the familial aspect as well. There's a lot of obviously anxiety and the natural anxieties you would have with sick family family members, and sometimes there's a bit of obstruction there in terms of care. So there's a lot of aspects of care that you have to be looking after. As I say, B5C, I won't really talk about, mostly respiratory, so similar things that you'll get on respiratory, hypoxia, gas, recurrent taking blood gases, assessing acutely hypoxic patients, maybe modulating them from B5C to B5B if they need NIV, liaising with the respiratory failure fellow is quite a common thing for these patients. There are some patients that are not respiratory and general medical patients. And C4C, so the locked ward on the 4th level, so got a small patient load, they can be quite intense. You don't tend to get a lot of calls from memory from C4C. They'll have normal medical problems as well as the psychiatric problems, but that's not as busy as C5A and C5C, which really take up the majority of your time. So top tips, this is top tips for any ward in hospital. When you're a resident, when you're a doctor or a registrar, whatever, you've got to be approachable. If you're new to the ward, introduce yourself. There's got to be a trust built with nursing staff or other members on the ward. If the nursing staff trust you, they're more likely to accept what you say. They're more likely to page you less if you can build this understanding that you are going to review patients regularly, you're going to come back to the ward on a regular basis, you're not going to, you're going to answer your page, and, they can trust you. There's a relationship to be built. You may be working with this team of nurses later in the year, you might do a rotation, so it's worthwhile getting to know the staff in the ward. So introduce yourself. Really useful for our patients on C5A, but also for the medical oncology patients. Who are the sick patients they're really worried about? If you can get to them before they leave, and often, unfortunately, as Andrew will know, the C5A residents are often on the ward after hours trying to fix things up. So often they're still there. So you can get a handover. What is the team deciding about this patient's treatment? They've got an aggressive disease. Is it still a curative intent? Is it taking a different turn towards palliation? Current issues, what's the plan for those current issues? You shouldn't be having to make life and death decisions in isolation after hours. There should be a plan. And if it's a new symptomatology or a new problem that's arising, then there's backup from the registrars, the medical registrar, and from the consultant. But if you can get a handover, that's good. And find out who the boss is. And the bosses can be contacted directly. So if it says Dr. Benson's looking after Mrs. X, call Dr. Benson. If you can't get Dr. Benson because he's away or at a conference, then you call the on-call consultant. For the bone marrow transplant team, call the consultant. Don't worry about calling the consultant directly. They'd rather you called early than you hold off and don't really know what you're doing. Often you'll go through the medical registrar, and the medical registrar will probably make a decision, or he will call the boss. They'd rather be called early. The patients are complex. So that thing about top tips, attend the ward regularly. I would usually do a little bit of a ward round and say to nurses, look, put it in the book, I'll come back if it's not urgent, I'll sort it. And I know you guys already are good at that, but just reiterate that, if you're doing evenings, just let them know that you're trustworthy. Try and get breaks. I know it's really hard, but if you can do, if nurses are offering sweets, take them, that's fine. Anything to keep yourself going. Like I say, in C5A there's usually a bit of a buffet going on. Partake in that buffet if you offer it to you. This is really hard, but you should answer your page promptly. And it promptly doesn't mean stop candidating the patient, walk away to answer the page. And it's just if you get the first opportunity to answer it, because that natural suspicion of nurses who think we're off in the golf course playing nighttime golf or something. There's some kind of cliche that we are downstairs drinking gin or something, God forbid. So if you don't answer the page, they'll just page you again. That horrible page and run, and they don't stop. So answer your page promptly and be polite, even if you do feel like screaming. It doesn't really get you any further being abrupt. This builds a bit of tension and this wears on your soul, so be nice. And ask for help from other people. So if you don't know how to do something, just ask somebody else, another resident. Often people have worked on that ward, have done a rotation. The med-reg, use the med-reg, a lot. Don't worry about asking questions. At this stage, you've got a lot of knowledge. So it's maybe not as crucial as last year, but still ask the med-reg. It's good for the med-regs as well. It helps teach them haematology. comes up in the exam is a good thing. Nurses, they do have a lot of protocols. So that thing I was talking about in haematology, there's a lot of strict training for nurses. There's protocols. The nurses know the protocols. They know what infusion's running. They know when they can break the infusion. They know what drugs are going to cause QT prolongation. They're very aware the patients are actually really well trained. So ask them. Ask the TL, whoever it is. What do you think? What's feasible? What's this patient had during the day? What else can I give? You'll get a lot of good information from the nurses. And consultants, don't wait to call consultants. Just call. Haematologists are not scary surgeons or cuddly teddy bears or people. And look out for each other. It's hard for the C5A to cover another ward, but if you're not busy and you know somebody in C5A is having, or C5C is having a terrible time, help out. So C5A itself, 25 patients. I think all the patients there are pre-ICU. They go off very quickly. They can come in with a bit of a fever and they just drop off a cliff. So just be aware that even though they look relatively well and they seem to be holding their own, young people will compensate and old people will compensate a bit, but then they will drop off the cliff. So I would say you want to get to them and review them quickly if there's a pace or if the nurse is concerned. So, these are obviously the liquid malignancies, so leukemia, lymphoma, myeloma, very occasional sickle cell patients come in, probably more now because our population is changing. And that's roughly it, that's the majority of patients. The bone marrow transplant service has anything between 3 to 17 patients who are having autologous stem cell transplants, so they're on blood cells back again after high-dose chemotherapy, or they're getting somebody else's bone marrow, so that's allogeneic stem cell transplants. They're all usually by definition heavily immunosuppressed and pre-treated. So they're at risk of unusual infections, fungal infections, viral infections, PJP, reactivation TB, anything and everything. So just have a very open mind when you see these patients. They could have infection growing anywhere. And as I talk about consultants, call the patient named consultant, or if they're not around, on call. If you make a mistake, the consultant's not going to scream at you. That's not my patient, you idiot. They're just going to say, that's fine, call somebody else. They're very, very kind of approachable. The common jobs you'll get, PACEs, unfortunately, are very common. For febrile neutropenia, is probably the most common one. New symptoms, and it could be anything from rash to diarrhea. The nurse is just concerned about the patient. As a man married to a nurse, I know that sometimes it's quite frustrating, this call of there's something not quite right, and that's it. There's like, what's their blood pressure? It's fine. What's their SATs? It's fine. What's their temperature? It's fine. Okay, so why are you concerned? Don't you know I've got 9 million other patients to look after? Senior nurses know something, and it is a kind of unknown sense that they have for a patient going off. It's probably just experiential. If, say, one of the TLs on the ward has seen a patient start to deteriorate, they'll have seen it 100 times before, so trust them. Electrolyte replacement. Some of the patients need huge amounts of IV electrolyte replacement, and that's usually because they're not eating or they're losing through diarrhea. Febrile neutropenia is probably the most common thing, the most common reason for people coming into C5A, and new spikes on the ward are a very, very heavy caseload. Pain, patients are often in pain, particularly the myeloma patients, but also the sickle cell patients when they come in can be in agony. It's very, very painful. And that's an emergency. You need to get to these patients quickly. Imagine sitting in pain yourself. It's not something you want to ignore. Bleeding, because of the nature of the patients, they're usually on chemotherapy. They usually have bone marrow suppression, and so they have low hemoglobins, low platelets. Their liver function might be disordered or coagulopathic. So they can bleed from everywhere and anywhere, and it's a good actual test of how to manage coagulopathy in these patients, which you can take across to trauma patients or patients who are in other wards. And nausea and vomiting, the chemotherapy, a lot of them have problems with nausea, even despite the numerous agents we give them for nausea. So sort of like survival tools, use your fellow residents, medical registrar, acute pain service. You often need to call them, particularly for people who've got bone marrow transplant, induced mucositis, or they've got terrible colitis, they've got something. So call the acute pain service. If that registrar doesn't pick up, Usually there's the other registrar on for anaesthetics who can come around and help out. Haematology registrar, so they're overnight, they're supposed to be on for lab advice and transfusion. So, you can't phone them up if it's a patient you're concerned about, you call the consultant. But if you want blood products, or you're concerned that you've given somebody blood products and now there's a problem, they're febrile, give them a call, okay? Or you're not really sure what to do, they've got some kind of strange blood group requirement which blood banks are being difficult about, call the registrar. Infectious diseases, a lot of the patients are infected. In fact, 99% of patients having chemotherapy will have infection at some point. So infectious diseases are a real guide and help for us guiding antibiotic use, and obviously with the new guidelines, we want to be appropriate and get the right approvals and so on. General haematology on call for that patient, and if not, then the on-call consultant, and then bone marrow transplant consultant for bone marrow transplant patients. So these are the things that you'll have to do, and these are the what to do when you have those problems. So febrile neutropenia is very well set out in terms of management. So if you just go to the internet and type in ABC of antibiotics, you'll get all the guidelines for infective problems within patients, and they'll have there's a little section down there for febrile neutropenia. So their definition is 38 degrees for an hour or for greater than an hour, and a single temperature of 38.3 taken by an oral thermometer. In reality, once they hit 38, it's going to be febrile neutropenia. The nurse is not going to wait an hour because patients deteriorate really quickly. So I'll show you that's a link to the antibiotic protocol, and there's one on therapeutic guidelines as well. This is the most up-to-date one, having been revised I think last year. And if you just type in ABC of antibiotics, it's there. So most patients, you need to culture them extensively. If they've got focal symptoms of the nose, and you'll do a swab. If they've got focal symptoms of gut problems, then you're going to culture their stool. But universally, usually, you're going to be culturing everything, being aware that maybe there's one system that's probably the source. But people can have co-infections, and particularly with these patients, because they're so heavily immunosuppressed, you've got to think of strange things, so fungal infections and viral infections or CMV. So culture everything that you can, blood, peripherally, Hickman line, PICC line, take a urine sample, do a chest x-ray on the ward. If they're neutropenic, they're better being on the ward, not off the ward. But if you want an abdo exam, you have to go off the ward. Nurses will ask you, are you happy for them to go off the ward? If they're stable hemodynamically, yes, I'm absolutely fine, because I need to get the image. If it's not really going to change my management and they're hemodynamically stable, maybe I'll wait till the morning. I'm going to start antibiotic treatment anyway. If they've got very tender abdomen, you might be thinking about neutropenic colitis. Do you need a CT abdomen? If it's not going to change what you do that night, you probably don't need it that night. If they're really tender and you think this is an acute abdomen, well, it's going to be surgeon and CT abdomen anyway, because the surgeon is going to ask for a CT abdomen. So I would consult surgeons, but I would also order the CT abdomen looking for colitis. And they might have a collection that they might want to drain. Although given that most of them are neutropenic, intervention is really hard. You don't want to do anything interventional with people with neutrophils in their boots because they won't heal. It's very dangerous. Our guidelines are antibiotics within 30 minutes. So tazocin and gent are the standard, and the range of gentamicin initial dosing ranges because of your age, or changes because of your age and your renal function. So between 4 to 7 milligrams per kilogram. You're severely septic, give 7 milligrams per kilogram. If they've got low hypertension, tachycardic, high temperature, give them 7 milligrams, maybe for once off, and they'll sort it out the next day. But don't worry. If they're renal failure, you're going to have to adjust that dose. But don't be scared of giving a bigger dose. And the guidelines, the ABC of antibiotics, gives you the milligrams per kilogram of gentamicin based on age. The backup used to be cefepime, but nowadays it seems to be meropenem if you've got beta-lactam allergy. So meropenem plus gentamicin. If it's a new febrile neutropenia, you should really be calling the consultant. If you're worried, call Medridge. If they've already, and this is kind of what I would do, if they've already got an established fever, they're on antibiotics for 2 days, I would usually change. And I might get ID advice as well. If the symptomatology hasn't changed, i.e. they've got nothing, they're just lying in bed febrile but there's no source, I would change. If there's any new symptomatology, I'd aim for my cultures towards that symptomatology. You're probably going to call the consultant to change anyway. You wouldn't do it on your own, you'd probably say that Mrs. X has got a fever again, she's had it for 2 days, are you okay with me changing antibiotics? Consultants will often add in things like vancomycin to people who've got Hickman lines. They may add in adjunct back in, they'll probably change to meropenem if they're on tazocin. If they've got previous VRE, they might get tacoplam or linezolid. There's a range of things, and it's often best just to call the consultant. This is the internet. If you just type in ABC of antibiotics, it just appears. Just type in ABC of antibiotics. It brings you to this website, and all the protocols are down the side. So the antibiotic protocols, policies, and guidelines. That one there has the neutropenic protocol, as well as lots of other ones. And it's really actually really useful. And that's what you get to when you go into that ABC of antibiotic guideline. You get the kind of list of organisms, infection rates, and what antibiotics to use. You'll have seen graphs like this before, but the reason we say 30 minutes to antibiotics is because the longer you wait, the more people die. So you're going to get the stickers from the nurse to culture what she can, and you prescribe the antibiotics, and the nurses there are very aware that they have to give it, and they're audited for how fast it took them to give antibiotics, partly from in-house and partly by ID. So, antibiotics saves lives. Other things that you'll get called to see on the ward, so it can be anything and everything. So I'll just start from the top and go kind of down the way. Neurological, well, patients can often be confused. They're infected, their electrolytes are off, they're probably not slept because they're nauseated, they're on high dose steroids. So confusion and delirium are not uncommon. Haloperidol is great for delirium. Lorazepam, midazolam probably make things worse, but haloperidol is good for delirium. Obviously, the normal things you would do about nursing one-to-one if you can, all those simple things apply. If there's an ongoing fever, then you may be thinking about infection. So if they've got new onset delirium and a fever, they're probably going to end up needing some kind of imaging, maybe an LP at some point soon. Particularly if they've got focal deficits. They could have a cryptococcus deposit because they're immunosuppressed. So always think, infection's got to be ruled out if somebody's got a new neurological symptom and a fever. You could have a mass lesion, you could have a myelomatous deposit, skull vault, and it's pressing into the brain. So, they're going to need imaging. Is it an urgent thing? You're dropping the GCS, you're going to do the normal thing you do, and you're going to image them. But if they're not dropping the GCS, it's probably something that can be discussed with the consultant. Wait till tomorrow. Emergencies in oncology, they're very few and far between, but spinal cord compression is one of the big ones. So myeloma patients can present with a mass lesion, lower limb weakness, flaccid paralysis, loss of sensation, and that's urgent. Urgent MRI, talk to the consultant on call, talk to radiation oncology, you're going to give treatment that night, you're going to call people in, you're going to call the med-reg immediately anyway because they need to be involved, they need to be assessed, get a level, a sensory level, get a good clinical assessment. If they've got a single lesion, often it will be neurosurgical, definitively take that lesion out or fix it. If they've got 2 or 3 lesions, often it's probably better under radiation oncology, but there's always a bit of toing and froing when you call radiation oncology or call neurosurgery. They want to know you've called the other one, I don't know why that is, but they always want to know that, you're involving both teams. That's just the way it is. But it's an emergency, so obviously you want to get in there early. Gastroenterological, most of the patients on the ward are going to be nauseated at some point. A few of them will get obstructed. They could have a paralytic ileus, or they could have an actual small bowel or large bowel obstruction. And you do your normal surgical treatment, nail by mouth, drip and suck, and get an urgent erect chest x-ray. Diarrhea, very, very common, particularly patients who are after induction chemotherapy or bone marrow transplant. And because of the immunosuppression, there's other things you would check for in the stool that you wouldn't normally check for in patients, say, in A5C. You would check for C. diff, salmonella, giardia, rotavirus, norovirus. You'd have to write all those down specially. If you do a normal stool culture, they'll check for salmonella, and I think they check for cryptosporidium, but you have to specify the other ones. Again, if they're tender, you probably want to think about scanning their abdomen. You might not want to do anything surgically, but you want to know if they've got, severe colitis. And any concerns, just talk to the consultant. or the Medridge, if you want to go through them initially. Bone marrow transplant patients, often they have this bouncing back and forth between having colitis, usually CMV reactivation, or graft versus host disease, or both at the same time. And the treatments are often at either end of the spectrum. You want to immunosuppress them, or you don't want to immunosuppress them. So those patients talk to the consultant. Someone's got a terrible colitis and they're having bowel motion 16 times a day, and you're concerned about them, talk to the consultant. Often they'll be on ganciclovir anti-CMV or foscarnet, or they'll be getting high-dose steroids. And the only really definitive way of telling if they've got one or the other is to do a colonoscopy and do a biopsy. Respiratory, a lot of patients are hypoxic, and the reason can be manifold. Infection versus fluid overload, because their albumin is really, really low. They've got engraftment syndrome, where you get this rapid weight gain and fluid buildup, or they've got APML, and they've suddenly developed lots of fluid overload from the actual treatment with ATRA. Respiratory, always think of the unusual infections, so these patients will have the normal things, but they can often have fungal infections, and you might end up ordering high-rise CTs because of that, and that could be after hours as well as during the day. The patients got cancer, and so this probably spreads more over to the medical oncology side of things. PEs are common. They've got active malignancy. They should be on thromboprophylaxis. If they're not, they're at risk of PEs. And then hematology patients, invasive aspergillosis is a real problem, and they often just bleed. They often don't have lots of hypoxia. They just hemorrhage into the lungs, and it's quite dramatic. From a cardiac point of view, there's not. Most of the patients who get to the ward who had a transplant have been assessed, so they've got to be cardiac fit to have the transplant. So that's not always a problem. Older patients, they could have ischemic heart disease and developed AML. So the normal problems that people have still exist, and the common things are common in terms of cardiac problems. Arrhythmias, because of all the electrolyte disturbance, you want to be quite aggressive, maintaining your potassium in a normal range and your magnesium in a normal range. And certain drugs can cause problems, and arsenic is one of the classic ones that can prolong your QT. You'll often get asked by nursing staff, can you look at this ECG, is the QT prolonged? Any questions? Call the Medridge. And the other reasons we're talking about, engraftment syndrome, hypoalbuminemia, the normal third spacing because of the albumin levels or the actual treatment and chemotherapy itself. Patients who have a disease like lymphoma and have a large burden of disease, and then they start treatment, all those lymphoma cells suddenly die and release their internal toxins, their potassium, their phosphate. They get metabolized, the proteins get broken down and turned into urate, and you can get this tumor lysis syndrome where the urate goes up, the phosphate goes up, potassium goes up, their kidneys start to die off. Most patients will be on allopurinol or IV fluids if they've got that risk. Sometimes they'll need resburicase to try and break down the proteinaceous buildup. That's not that common, partly because it's really expensive, and partly because most patients with a high tumor burden are usually on pre-phase prednisolone, so they'll get 4 or 5 days of prednisolone to shrink down a large burden of lymphoma before you actually hit them with chemotherapy, so that you don't suddenly cause a massive tumor lysis. But there's always that risk, so look at the urate, phosphate, potassium. If the team have not organised it and the creatinine's rising, ask for a urate. You can add it on to the day bloods. So keep those patients well hydrated, usually 4 to 6 hourly fluids. If they're old and at risk of fluid overload, you might want to give some albumin as well to kind of maintain some kind of oncotic pressure. But sitting up in bed and watching their SATs is probably just the other reasonable supportive thing to do. Unfortunately, patients on transplant service often have cyclosporin as one of the drugs to prevent rejection. And when your kidneys go off, the cyclosporin levels can go very high and can get very toxic and shaky and nausea and vomiting and so on. So watch out for people who are getting acute kidney injury. It's worthwhile watching what their cyclosporin level is doing. Or clinically, do they have signs of cyclosporin toxicity? Hematological problems, well, bruising and bleeding are probably the main things because of low platelets. So a transfusion with platelets and coagulation factors is a very common thing. There are some problems with transplant. Transplant can induce TTP. Cyclosporin can induce TTP. where you get a rapid drop in platelets, you get a rapid drop in your red cells, and you get fragments on your blood film and you're coagulopathic. And you know, it needs a lot of transfusion support. If you've got any questions about somebody who looks like they're dropping all those markers, just call the transfusion registrar about support and talk to the consultant, or just go straight to the consultant. Often somebody like myself will need to come in and look at their blood film to see if they've actually got TTP, because it's diagnosed by looking for fragments on blood films. And the treatment is often a plasmapheresis. But any questions about transfusion, give the transfusion registrar a call, and switchboard has their number. Not far to go. So other things that are important, uncontrolled pain. So it's an emergency. You know, as I said, you don't want to be sitting in pain. Myeloma probably the more common one to cause bony pain, but you know, people can be in pain because of mucositis or colitis. Solid metastatic breast cancer, especially the bones, and it's very, very painful. So you want to get on top of that pain quickly. So give adequate doses. Don't be afraid to give IV. If nurse won't give IV, you give IV. You know, I'd rather stand at a patient's bedside, give them little titrations of opiate till they're comfortable, than just to ask a nurse to give subcut morphine and she's going to be 20 minutes to do it. I'd rather say, well, let's do this now. It's an emergency. Usually it's treated as such and patients get adequate analgesia, but you'll know yourself, patients' families or patients themselves coming to the nursing desk saying, you know, my dad's still got pain, is there anything we can get? And I think we get a bit battle weary and forget that actual patients are having a really distressing time. So, you know, it's just going to be horrific for them. So get good pain control. Involve acute pain service, involve the palliative care if they're known. If you have to call them after hours, call them after hours. It's one of those oncological emergencies. And terminal patients are their own kind of special branch of that. You know, you're supposed to be giving patients a well-ordered and controlled symptom control in that terminal phase. And it can be done really well. There's no reason why you can't give painkillers. You know, you're not worrying about sedation. You want people to be comfortable. You're giving them doses that are adequate. You're not trying to go too far, but you're trying to give them adequate doses that are really, really difficult time. There's 101 different nausea drugs you can give. Often patients will be on Maxlon and ondansetron if they're getting chemotherapy. They'll often get lorazepam if they're quite anxious about chemotherapy and have anticipatory nausea, but you can use it on top of Maxlon and ondansetron. Haloperidol is really good as a fourth line. Dexamethasone, they'll often be on that for the chemotherapy protocols because dexamethasone is a very good antiemetic, but you can give it as well if you want. Stematol, 5 milligrams PO, I think they can give some IV. I prefer cyclazine. It works on the same receptors and it's probably slightly better. It's 50 milligrams IV or orally, or IM if you're really cruel, if you want to, 3 times a day. There is a special form to be filled out, but if you're doing after hours, don't worry about that. The pharmacist will sort that out the next day. Just prescribe it and the nurse will give it. And they usually have it on the ward. Hypercalcemia, again, probably more a problem in myeloma and solid organ metastatic disease, but it's an emergency. You know, you want to be giving people lots of IV fluids, giving them bisphosphonates IV if you have to, and definitive treatment. That might be steroids, starting steroids for people with myeloma. Other stuff, electrolytes, yeah, don't worry about giving people 200 millimoles a day of potassium, because some patients need 200 millimoles of potassium because they're literally crapping out 250 millimoles of potassium. And that's not uncommon in patients, particularly transplant, who've got CMV colitis or graft-versus-host disease. You know, they're not eating and drinking, they're just going to the toilet all day, it's pretty horrible. Give them adequate doses. So look and see what the team have given. If they've given 50 millimoles and it's gone from 3.5 of potassium to 3.6, there's no point giving 10 millimoles, you need to give bigger doses. And the nurses will usually say, you give a bit more anyway. They're usually hinting that they know the patient needs a bit more. So check what the team have been giving. Some of the tablets are quite big, particularly the Sandoz and magnesium. Patients don't want to take them. Don't worry about giving them IV. Usually the nurse can find time on the Hickman line to give them stuff. So IV is probably more of a common route than orally for the acute patients. Transfusion, so our local guidelines are usually transfuse red cells if their hemoglobin is 80 or low and dropping. You've got active bleeding. Platelets are less than 10 because once you get below 10, their risk of spontaneous bleeding takes off like a rocket. Above 10, it's not as bad as people think, or if it's less than 50 and they're bleeding again. Patients will often develop antibodies to HLA proteins on platelets because they've been transfused a lot, particularly, again, transplant patients, and they may be getting special units from blood banks. So if you phone down and order platelets, they may say, look, this patient's getting HLA matched platelets. Is that okay? Yes, of course, that's fine. Give CMV negative for CMV negative patients. Why would you want to give them a virus which could reactivate? So if they're CMV positive, doesn't matter, you can give them whatever. If they're CMV negative, give them CMV negative. If a new patient turns up and you don't know, you know, a young woman, maybe somebody has not been got an acute leukemia, give them CMV negative. You don't know, you may as well play it safe if you can. Irradiated products, we irradiate products because you kill off the T cells in the product, in the blood product, and the T cells in the blood bag can get into the patient. They're immunosuppressed, and those T cells can take off and attack the patient. So that's transfusion graft versus host disease, not bone marrow transplant graft versus host disease. So something different. So we irradiate products usually for all our patients because they're immunosuppressed. Transfusion graft versus host disease is universally fatal. So if it starts, it's not very common, but if it starts, that's it. So you won't usually be asked, do you want to give unirradiated products? They're usually all irradiated. But just be aware that that's the reason why we do it. Transfusion reactions. Well, the patients are often febrile, and then they give blood, and you're like, well, they're febrile because we're giving blood, or were they already febrile, or should we stop, or should we keep going? I would say that if you stop the transfusion, you assess them. If they're hemodynamically stable, with no new symptoms, I would start back again slowly and see how they get on. You know, they need the blood. If you're really, really not happy, then that's fine, transfusion the next day. After transfusion is always a problem. Your team should really be transfusing patients during the day, because the majority of transfusion reactions actually happen at night. Not because there's something to do especially with the moon and the sun, it's just that's when transfusions seem to happen most. And it's a terrible thing because that's when there's least doctors in the hospital. So if you look at transfusion rates, it just takes a request, and the blood goes down, and they get cross-matched, and then everything else is given in preference during the day, and then the blood comes up at night, and then that's when you get your problems. So stop, assess them. Have they got pain at the site of infusion? No. So it's probably not septic, they're probably not having an acute hemolytic allergic response. They've got a bit of a fever rise, but not that bad. The blood pressure's okay, I would probably still go. If you're not sure, just talk to the med-reg, talk to the transfusion reg. Just talk, just ask somebody, don't worry about asking somebody. So overall, the patients are really complex. This would be my advice for anybody doing the shift anyway, whether you've done haematology or not. There's so many people involved, infectious diseases, the surgeons, the haematology team itself, there may be a bit of immunology going on, there's probably the transplant team going on, so, sometimes the acute pain service. Just ask, because it can get very complicated. And consultants are probably more important to be talked to in haematology than other teams, because it's a small speciality. Patients and consultants often know each other very well. They're going to be seeing that consultant for a long time. And by the very nature of the kind of patients, there tends to be, hematology consultants are quite attached to the care of their patients, and they don't mind getting called at all. And it doesn't matter if they do, because it's not about the consultant, it's about the patient, so who cares what the consultant thinks? It's really about the patient. So yes, good luck. You've all done the shift before, and if you can get home on time, make sure you get out of there, because you know what it's like. Okay. Any questions at all? I'm just looking at most of you I've seen on the ward doing shifts anyway. Has anybody not done an HR shift? Really? Okay. Anything you want to ask?
Does the same thing apply overnight in terms of calling the consultant?
Yeah, anytime.
Okay.
Yeah, don't worry, just call. They're really, really complex. And there could be a complete change in direction of care at 4 in the morning. They might actually go for a scope if they're bleeding. They might be naked, but maybe they're going to bleed to death and just going to have to take the chance and scope them. Or maybe they're going to palliate them there and then. And it's not been explicitly discussed. And that's a problem with all, sorry, right now, in a second, in haematology, oncology, there is, I think, a general delay in having that conversation about this could go wrong. And what do you want us to do if this goes wrong? I don't know why. You've got acute leukemia, that conversation should happen up front. But often it doesn't, and I don't know why. And it's a difficult situation to be at 2 in the morning, but it could be that you're going to be, it wouldn't be you. I'd be asking me or the med reg, but could you come and have this conversation? If you're confident to do it, that's fine. But I would usually have backup if you're going to have that conversation. You know, this doctor wants to change things. That shouldn't be your responsibility at all.
Does that include like a new febrile neutropenia if they're otherwise stable? Would you still call it?
So if the new febrile, yeah, the nursing staff are just going to say, have you called the buzz? No, they're literally standing here. Have you called the buzz? It's, I mean, the brick wall, this is the brick wall that you're hitting your head against, is a lot is the nursing staff. Because we've always done it this way. And they do it that way in concert with the consultants, because all the protocols are drawn up by senior nursing staff and consultants. So the consultants are happy to accept calls because they know, because they wrote the protocol. You know, they know that they'll get a call. They'd rather know. Patients just go off so quickly. So if they've got a new symptom, the consultant might say, oh, I want an MRI right now. You know, obviously they've got maybe disseminated cryptococcus, you know, something. So it could completely change what you do. You might be starting an antifungal agent you've never heard of because they've got a clinical sign which is you know, defines the care of the patient. So you call. Any other questions? Have you had food? You should have some food. Thank you very much.
Thank you.